This morning, we're lucky to have two of our wonderful assistant professors talk to us about the Stanford Biodesign Program. And there's been a strong collaboration and relationship between the Department of Surgery and Biodesign, first by leadership with Dr. Tom Crummell, but second by just a natural fit of surgeons being very hands-on and solution-oriented, finding ways that we can create devices and innovations that will really further the care of our patients. So Dr. James Wall, Assistant Professor in Pediatric Surgery, and Dan Azagury, who's an Assistant Professor in General Surgery, are going to talk to us about the program and how we train the next generation of surgeon innovators. So thank you, guys.
Thank you. Thank you very much. We're really happy to present this morning, and what we want to do is show you not sort of theoretically what we do, but try to really showcase what's actually been done by the people in the department, and tell you a little bit about what biodesign is, and maybe also a little bit about what biodesign is not. And there is a little perception sometimes that biodesign is essentially some doctors that will wake up some morning and have this aha moment and brilliant idea, and then they will ask a bunch of engineers in biodesign to build the device for them, and that's not what it is. Biodesign is about collaboration, and it's about a teaching process where we build teams to work together and to learn how to innovate. And it's an education program. It's a fellowship mainly, and you'll see some of our past and current fellows this morning. But the goal of biodesign is really innovation can be taught. None of us have the sort of Steve Jobs changed the world. We woke up this morning and we know exactly where we're going to take this 20 years from now. But all of us have the ability to innovate and to change the way we practice medicine every day. It's just a matter of unlocking that, figuring out how to do it, and be able to then do it time and time again. And the way we teach this is a pretty simple process, and the underpinnings of the process is that instead of having a technology and then finding the application for it, which the reps that come into your OR are very good at that. They have this new gizmo, and they will tell you how much better it is at doing something, and you're looking at it being like, yeah, sure, but I don't really need this. And so big companies are very good at doing that. The process that we teach in biodesign is the opposite. It's really trying to figure out what people need. And by people, we mostly mean the patient. But it also means the provider, the surgeon, anybody else involved. But it's about finding the need and developing the solution to answer that need, so that when you have that need answered, you have that new solution, you know it will be something that people will want to use because it's actually going to solve a problem they have in their life. So pretty quickly, I'll run you in about 5 minutes over what we do during a fellowship year. It's a team of fellows with different backgrounds, as I'll show you, and we go through a process where we identify an unmet clinical need, then invent the solution to answer that need, and then start to plan how to implement that solution in real life. That's essentially what the fellowship is about. And as I said, it's about multidisciplinary teams. These are this year's fellows. So we have 12 fellows every year. As you see, they really have diverse backgrounds. And usually by diverse background in this room, going from general surgery to vascular surgery is already the stretch, right? The diversity when we talk is typically, okay, colorectal versus, MIS. Here it's real diversity. What it means is it's engineers that can be mechanical engineers, computer science, electrical engineers, people with an MBA, physicians that can be surgeons, nephrologists, and interventional radiologists, et cetera. And what they do is they go through this design thinking approach that a lot of people are familiar with. And the core of this is put yourself in the user's shoes. figure out what the future user of your solution has for a problem, and then as you try to develop the solution, don't think that you have the solution. Figure out if the prototype you have would fit your future user. And this is relatively simple if your user is one person who's going to use your app. It's a little bit more challenging when your user is essentially the healthcare system. And the healthcare system has a lot of potential user or a lot of people who are going to influence what your device needs to accomplish in order to be in clinical practice. You can't come up with your device and then, give it to one of the surgeons tomorrow morning and say, hey, try this out, see if it works. Right? There are thankfully some barriers to doing that, but you have to take these barriers into account early on and know how you're going to get this device through the FDA, how this is going to get reimbursed, how the hospital is going to pay for this, so that ultimately your user can use it on patients. And so the fellows will go through a pretty long needs finding process, and that is independent of their specialty. So we pair with a department every year as a little bit of an excuse for the fellows to be able to roam around the hospital freely, and they will follow interventional radiology, oncology, whoever it is that year, and follow them around the hospital looking for unmet clinical needs. And that's relatively easy. They come up with hundreds of needs over a period of about 4 to 5 weeks. And finding problems in a hospital is never an issue. That's the easy part of the program. The harder part is trying to find which of these needs are actually worth solving. And so they will screen through these needs using some metrics to figure out which ones are the ones that have the most value if you were to be able to solve them. After that, there's a short time, which is the fun part, where you actually start inventing things. And that, again, is not usually the challenge. If you have enough time, caffeine, and smart people in a room, they'll come up with a great solution. And the challenge is, has somebody invented that great solution before you did? And often that's the case. And if that's not the case, are there any other issues that would impede that solution from making it out to the real life? And so that's the next part of the process, where you take your solutions and you screen them again to see, has somebody invented this before? Is there some sort of model to reimburse that device to get paid for that cost that you're potentially generating? And does the solution actually work to answer the need that you've identified? And lastly, the part where you implement this in real life is not something that's really part of the biodesign year in it by itself. The planning is. By the end of the fellowship, fellows have a plan on how they want to take this forward. Is this something that is a technology that needs to be licensed to a large company that's going to take it forward? Or is it something that you're going to take on your own and start your own company? Or how are you going to develop this device and bring it to the market? Because the only way your device is actually going to help patients is if it is on the market, somebody's willing to pay for it to be able to use it. So they'll take into account all these different factors and lay out a plan for the next 4 to 8 years to develop their device and go through the hurdles of what are the things that could still essentially break a good solution. Because there are a lot of factors out there that will impede you from taking this great solution that might solve a really important need but still not be able to commercialize it in the end. So, as I said, rather than really try to bore you with more of the process part, what we want to show you is what actually happens during the year. And we are lucky that a lot of the current residents and even some of our faculty in surgery have gone through the process. A lot of you are familiar with it. Some of you are current faculty fellows or have been faculty fellows as well. And so what we would like to spend the majority of our time doing is showing you a little bit of, okay, if you take that process and you apply it, what do you come up with? And so I'll let James take over from here.
Cool. So we asked several people to come talk. You see the names up here, familiar to you. It was under the premise of giving grand rounds. What they don't know is I actually talked to Mary ahead of time. This is a Shark Tank, and your future at Stanford depends on this. So good luck.
Great.
You got each person's going to give 5 minutes, and we are going to be strict.
Great.
And Lauren, let's go. Let's hear what you were up to. So Lauren came to us. Lauren Wood, as you all know, is one of our residents. She was actually a medical student when she got involved with the Biodesign project. It was a project out of the graduate class, not the fellowship. And she came to us on the Med Scholars Program and rocked and rolled. So let's see what you were up to, Lauren.
Great. So as Dr. Wall mentioned, I'm currently a second-year general surgery resident, and I wanted to talk with you today about LifeBubble, which is a device that was born of the Stanford Biodesign Program back in 2015. And as you mentioned, I was involved as a medical student on the project. And so the idea behind LifeBubble came about in the deep dive into trying to understand the care that's being provided to neonates in the NICU. And so we realized that to this especially vulnerable population, about 200,000 plus catheters are placed in neonates every year. And this is in the United States alone. So if you can imagine, it's a bigger worldwide procedure. And so one of the issues, the main issues that we faced or that we realized was that about 5% of these babies, and that's more of a conservative estimate, the estimate can range anywhere from 5 to 15% of children or of neonates will contract a bloodstream infection, many of which are associated with the presence of a umbilical catheter. And unfortunately, particularly in this population, some 10% of these babies will die because of their bloodstream infection. And so when we wanted to try to understand how can we target this problem, we turned to our adult population. So many of us are familiar with the placement of central lines in adults, which is a little bit of a different design problem, but here we see the adult standard of care for actually protecting central lines. So many of us are familiar with, once the line is placed, how to actually protect a central line. There's an occlusive dressing that's included in the central line kit. And as you can see, it's a sterile dressing. It's completely occlusive. It protects the site of catheter insertion right at the site of parallel insertion to the skin. It's a standardized method of protecting the site of insertion. And it's also really simple for the user. So that's one major user-centered positive aspect of the occlusive dressing. But when we take a look at what's going on with neonates, we have one design problem that is pretty apparent. So you have a catheter that's inserted perpendicularly to the skin, so that's design problem number one. And then secondly, so in addition to having sutures that secure the site of insertion right at the umbilicus. You have pieces of non-sterile tape that very frequently nurses will use in this goalpost or tape bridge-like configuration. It's an exposed site of catheter insertion, and it's also not standardized. So you see a wide variety of ways that our healthcare providers will use to try and secure the catheters themselves. It's also quite time-consuming as well. So this is where the idea for LifeBubble came in. It's a silicone-based catheter stabilization device that has these major aims to protect the catheter and stump interface. It's meant to standardize the process of stabilization and also vastly improve catheter securement as well. And as you can imagine, something that we're all interested in is saving our time. So it simplifies the process itself and saves time pretty dramatically. This is a video. They're set in 5x of the process of stabilization using LifeBubble. And so just to give you a sense of where we're at now, so thanks to grants and seed investments, we are getting to a place where we're going to get LifeBubble in the hands of early clinical partners and onto babies this year. So the major goals of LifeBubble is to save money, save time, and also ultimately save lives. Thank you.
We'll take questions. Yeah, awesome, Lauren. All right, next up is Patrick. So everyone knows Patrick from the vascular side, and Patrick's one of our current fellows. So what have you done for us lately, sir?
Okay. I'm going to talk to you guys about stroke. Stroke is a devastating event for far too many people. It's the #1 cause of long-term disability and the #2 cause of death worldwide. But not all strokes are equal. The worst strokes by far are large vessel occlusions, and they account for about 270 strokes a year. A large vessel occlusion occurs when a blood clot forms in a major blood vessel of your brain, leaving a large amount of tissue at risk to die. The most notable patient population that's at risk for these strokes are atrial fibrillation. In this disease, the heart quivers, clot forms, they get shot up to the brain. Most of them go to the anterior circulation, and they cause these large vessel occlusions. Now, there's 5.2 million Americans that have atrial fibrillation. It's expected to grow by 7% a year. But the subpopulation we're most concerned about are these 750,000 patients who carry a 10 to 14% risk of stroke a year. Now, that might not seem like a lot, but if you look at a 10 years of a patient life, that goes up to 65% of stroke during those 10 years. And yes, these patients should all be anticoagulated, but unfortunately only about half of them are for a variety of reasons, but mostly they're older, they fall a lot, they have risk of bleeding. So these patients have a real stroke risk. There's nothing that we're doing really about preventing stroke. And although I painted this bad picture, over the last 10 years, we've developed great treatments for these large vessel occlusions. We have mechanical thrombectomy catheters, which can go into these blood vessels, remove the clot, and outcomes have really changed. But this is with the assumption that you get there on time and get these life-saving treatments. So when a patient has a stroke, someone has to recognize the stroke, someone has to call 911, they have to get to the right hospital that has treatment capabilities, they have to be diagnosed and treated all within standard windows of treatment times. Now, we've invested billions of dollars to decrease the time from 911 to treatment, but we've only been able to impact the patient journey in the probably scale of minutes. We've noticed that the biggest gap is patients being able to call 911. We've met endless patients who have sat at home for hours or even days not being able to call 911. And why does this happen? Well, a quarter of all strokes happen in the middle of the night, and they sleep through them. Other strokes affect the right parietal, and they're left with neglect. Other strokes, they're so disabling that people, especially if they live alone, the idea of calling 911 is an unsurmountable task. This leaves 90% of patients with large vessel occlusions not getting to the hospital on time to get treatment. But we thought, what if we could help with this diagnosis of stroke on these high-risk patients? And that led us to our needs statement, a way to detect large vessel occlusive stroke in high-risk atrial fibrillation patients who are not anticoagulated to reduce the time to intervention. Now, we believe EEG technology that's used in neuromonitoring cases is probably the best technology for this. It's continuous, it's real time, and it correlates well with cerebral blood flow. Here in this simulation, we have healthy brain, and you can see that the EEG is symmetric and has your normal frequencies. Within seconds of a large ischemic stroke, you lose that symmetry, you lose a high frequency, you lose amplitude, and you're left with this low frequency waveform. We want to automate this process, quantify this process to detect stroke at home. Now you might be thinking there's dozens of wearable headsets out there, plenty of EEG headsets out there, we're going to make an EEG headset. Unfortunately, we've talked to patients, they don't want to wear a headset all day. They don't want to be labeled as a stroke survivor. We also know every minute counts, and we can't have patients leaving their headset on the side of the bed like a CPAP machine. They have to be wearing it all the time for the lifetime of a patient. We also know when you have a wearable EEG headset, there's a lot of artifacts and noise that comes about from hair and the scalp and the skin. So we know this can't be a wearable. We want to implant this EEG technology in the loose areolar tissue. We want to percutaneously place this through a single incision in the back of your head. This is a form factor. It's made of flexible electronics. It's going to cover all the lobes of your brain. All the electronics are embedded in the array. We have a battery that we expect to last 5 years. We have a geolocation system which locates the patient, and an alert system which will send all the critical information with the patient to emergency medical services to get the patient to the hospital. Now, I've shown you this potential prototype, but what would this do? We've modeled out all the data looking at the biggest thrombectomy trials, and if we could offer this to patients within 60 minutes of a stroke center, which is the majority of the patients in the US, and this number is growing, and we can conservatively say that we're going to be able to treat patients within 3 hours, well, the mortality from these strokes would go from 1 in 4 patients to only 7% of patients. And the amount of percent of patients that live independently after these strokes would go from 22% to 55%. Thank you.
Thanks, Patrick. All right. So next, the famous Dr. Blevins, who was a Biodesign Fellow last year and is in her second year now actively developing cool technology.
All right, thank you guys so much for having me. I'm here as a part of a team, as is the Biodesign Way, and we're really hoping, our vision is really to increase the availability for universal percutaneous endovascular procedures by enabling a closure device. So of course, as with all of these, this starts with an observation. So I'd like to introduce you to Gary. Gary's a 77-year-old gentleman who has an abdominal aortic aneurysm. In his evaluation, his physician decided that, hey, I can go ahead and do this EVAR. Looked at the femoral arteries, saw there was a little bit of calcification, but still made the decision, I'm still going to try to do it percutaneously because there's so many benefits with it. So as is standard right now, did the 2 per-closed devices. Got to the end of the case, everything else went fine, but the patient was still bleeding. The per-closed devices failed. Tried to salvage with the 3rd device, but unfortunately, still bleeding, which led down to a surgical cut down. As does tend to happen with these groin incisions, Gary then got an infection, had a wound vac, longer hospital stay, and more costs to the system. We know that patients with severely calcified femoral arteries have no minimally invasive closure option. We know there's an aging population, and with that aging population, there's an increase in indications for minimally invasive cardiovascular surgeries. As saying, these big open surgeries, including heart valves and aneurysm repairs, are going from big open operations to these really cool minimally invasive procedures that just require a small incision through the femoral artery. However, as these patients are also getting older, there is calcification in the arteries, which limits closure options. And femoral artery calcification is an independent determinant of failure for these currently minimally invasive technologies. So we know for calcified arteries, there's no minimally invasive closure options. The per-closed ProGlide doesn't work with vessel dissection, the needles can't get through the arterial wall, and so there's just not an option right now. Surgical cut down is currently the gold standard, but it's a big incision, it's more pain for your patients, you get more complications, wound infections, and patients stay in the hospital longer than they would if it was just a small incision. There's an alternative surgical technique known as a surgical fascia suture technique, which still requires a skin incision, but it's less invasive than an actual surgical cut down. It's used as a bailout method at several centers in the US and is a primary method of closure for all femoral artery access at some centers in Europe. So then our approach is then to take this surgical invasive technique that's been validated, studied in clinical trials, including randomized controlled trials, and convert it into a minimally invasive percutaneous technology. This makes this solution available for all interventional proceduralists, minimizes the invasiveness of procedure, and hopefully gets patients home sooner. We're very happy to announce we just got a $100,000 grant with Dr. Lee to take on or continue working on this project.
Awesome. Thank you, Kate. All right, next we have young Professor Kethman, who has been the most mature of the Biodesign Fellows, and he did it 4 years ago?
Yeah.
And he's going to talk to us a little bit about TUYO.
So my original team that started this company, were made up of a pediatric cardiologist who finished her fellowship about 1.5 years ago, a mechanical engineer who worked at Intuitive, and then a electrical engineer, PhD computer scientist. And so our needs were varying in both pediatrics and in general surgery, and one of the top needs that we identified and that we ultimately brought forward was TUYO Health. We're dedicated to improving the lives of children with asthma. Sorry about the font. The 2.9 million children with asthma experience daily symptoms in the United States every day. This results in $6.4 billion in direct healthcare expenditures, over $600,000 in emergency department, or over 600,000 emergency department utilizations. It's a leading cause of school absences in children, and it leads to significant caregiver stress. About 50% of the time, parents are missing work and school, depending on if their child is well controlled or poorly controlled, and it results in about a 4.1 hour work productivity decrease in those parents. And so we envisioned a solution that leveraged the ubiquity of sensor solutions in our homes with machine learning to improve outcomes with chronic diseases. We're initially focusing in pediatric asthma. And we do all of this with a sensor that lives passively underneath your bed. And we measure key physiologic indicators. So I'm sure a lot of you could imagine a lot of solutions in other clinical areas. But here are the key things that we are able to measure with this sensor through the mattress without contacting the child. Heart rate, sleep quality, respiratory physiology. We can actually build inspiratory and expiratory curves based on the vibrations and the movement of the child at night. And then we can measure cough frequency. All of these have actually independently been demonstrated. So before we had a clinical trial to demonstrate this, we just had a bunch of little studies that showed that these factors were important for determining the health of a child with asthma. And so now we've taken that forward and developed some data around that. So we take that data and we wrap it around a mobile application for the parents. The most important thing that we discovered in our initial clinical trials were that a lot of the problems are around just having the medications when you need them or getting a hold of your physician when you want to. And then number one, knowing that your child was sick. So a lot of our parents, what we discovered was that most of them, if you ask them when they're in the emergency department, how's your child been doing for the past couple of days, they can tell you, wow, in retrospect, for the past couple of days, my child's probably not been doing as well as he or she normally has. And so this sort of begat this opportunity for us. And so what we're attempting to do is to develop a glucometer for asthma. So something that exists for diabetes, we don't have for asthma. So since leaving the Biodesign Fellowship, we developed a third-party IP and regulatory strategy. There are 2 patents pending on our technology. We completed an initial verification trial here at Stanford. So we took the technology that we developed, the sensor solution, we brought it to one of the pediatric sleep labs, which we actually have here at, actually it's with a partnership with El Camino. And we worked on 20 children. And so we validated our heart rate sensing, our cough frequency measurements against gold standard polysomnography. And we demonstrated that our sensor was accurate to plus or minus 10%, which is about what home polysomnography tests are. And then we took that trial, and for 6 months, I drove around the Bay Area to children's houses who have moderate to severe asthma, manually collecting data from our sensor systems. We did that for about 18 children. And the data that we determined, or the data from that trial showed that we could actually predict the onset of asthma exacerbations about 3 days prior to the attack with an 85% sensitivity. And so the data from that was just accepted for publication yesterday, actually. So we took that data and we went and we raised $1 million and launched the company out of Stanford, and recently leveraged that $1 million to run a randomized control trial, 16-week, 260-patient prospective trial in partnership with Evidation Health. The interesting thing about this trial is that it was completely remote. All the data collection was done through our Wi-Fi connected sensors and the mobile application, and children all over the country enrolled in the trial. We randomized those children to just having a sensor and no app, and having the app with our asthma educator service. And that data preliminarily looks very good, and we're going to be reporting that in this coming up month. And we're now currently raising $6 million, so if it's Shark Tank and you want to invest, let us know.
Thanks, William. All right, and last but not least, really happy to have Derek Amantula with us. So Derek was so what we've seen so far is a medical student, and Lauren, we've seen our trainees who were full-time in the fellowship. Derek did the faculty fellowship, which a couple of our faculty members have done, Oliver Alamini, Cindy Kinn, and we're hoping more in the future. But Derek is in the Department of Orthopedic Surgery, for which we don't hold that against him too much. And he's, sorry. Like myself and Dan, is kind of trying to think about how to do innovation within the confines of the academic center and make it into a career and hopefully get promoted. So we're excited to see what you're up to.
Yeah, I think the thing that we can take from this is that we actually have a lot of common needs. We are actually trying to solve a problem really near and dear to surgeons. So there's 50 million operative cases, over 50 million in the United States, of which 25% have an object that goes missing. And so the common thing that we have is that we all kind of want a way to track surgical objects during any operative case in order to reduce miscounts and improve cost, safety, and efficiency. The real unfortunate part here is that there's really nothing that exists in this space other than people. And people are probably the least efficient thing in this process. I think my video didn't make it into this, but we have a case where we're missing an object that got lost in the garbage, and it takes about 30 minutes for everyone to search for everything and figure out what's going on, recount and count again, increasing the amount of unsafety to the people in the OR, to your anxiety, to the patient. So that's represented here as the low efficiency solutions, searching, radiographs, and kind of what I would say very poor counting devices. Finally, there's some new technologies that have come on board, and you've seen Stanford adopt this recently. This is either RFID tagged objects or bar-counted objects. And there's some real problems with these, although they address a specific inefficiency in the system. Those particular things, they cost money, and they save the hospital some money, but they also are missing some particular key points. They can't address the miscounts or retentions in specific objects that we care about. They really only address sponges because needles and instruments require different things than sponges themselves and don't lend themselves to labeling. Specifically, needles are too small and can't apply an RFID tag to a needle. The capital expenditure to RFID tag all of our instruments is way too much, and if you apply tags to instruments, they fall off. Additionally, all these things, all these labeling technologies are active. So at the end of the day, you're still people inputting the data and putting the data out. We really haven't changed the process of the count at all. I really wish I could show you our prototype, but we have a machine learning algorithm that can utilize a video camera to count every object in the OR. We have that available for now 5 objects, and we have plans now to expand that to enough objects for 1 surgical procedure. We do have some issues with needles, but they're overcomable with cameras at this time. And the really great part is that there's absolutely no regulation on top of this at all. This is really a class 1 device with very little, only when we really look at the patient may we actually encounter the need for a 510K. We just received a Coulter grant for $100,000, and we're going to work on changing this from prototype to product, and you may see this very soon in the Stanford OR.
Awesome, thank you so much. This guy on? So I think, I hope that gets across what we do at Biodesign. I think one other big misconception that's out there is that you have to be kind of an engineer and a doctor. I mean, when you look at this group, or you have to be brilliant like a Dr. Fogarty, myself included. I don't think anyone in this group is particularly special, but if we, in fact, I mean, look at it. We've got 2 PhDs in basic science, and Derek and Katie that we've rehabilitated to work on technology. You know, Kethman does have a background in engineering, but he's the only one. So, you know, when you think about it, you don't have to have all those components. It's really about being a collaborative team and going through a process that helps you find where the unmet needs are. So what have we done with the program? I'm going to talk just a little bit about the outcomes. We focus on our fellows, but I wanted to highlight that we do kind of reach out to the undergraduate, graduate community, as well as the faculty. So we also, in addition to within the walls of Stanford, we train people to do these programs around the world and have expanded our reach internationally. And we also have a program for executives from companies who come here and learn about our approach. So Innovation Fellowship's the cornerstone in terms of reaching out to the university. We now have 6 undergraduate courses that range from fundamentals of what we do to focusing on mobile health and other things. We have a graduate class that's always oversubscribed. We run some grant funding, most notably the Coulter grants that many of you know about, from which this department's done very, very well in terms of not only the original grants, but also follow-on funding from other sources after receiving Coulter grants. Our global initiatives, we started a program in India about 15 years ago that was very successful and have then translated that model of training internationally to Singapore. Dan's now involved in Japan. We're looking at China and other places in Europe as well. On an annual basis now, as a center for biodesign, we touch about 20 fellows a year. We touch about 200 students in terms of education. We touch about 48 faculty members through grants in the faculty training program. We have 16 global trainees at any time, and we have almost 100 executives now that come. In terms of kind of the numbers, over the 17 years now of the program, there's been about 900 disclosures, of which probably about 1 out of every 4 of those converts into some type of patentable invention. About approaching $1 billion in real-world funding. It often starts with academic funding within the academic center and then translates out to private funding if there's a real opportunity for a sustainable product, company, or device. In terms of the companies, this is something that we talk about a lot. It is not our goal. Our goal is purely an educational program, but one of the outcomes is companies. I mean, think about the operating room. Would you be able to do anything in the operating room without companies delivering products? We'd be useless, right? I mean, Stanford can't make that stuff. So, you know, it's not our primary goal to commercialize, but you kind of have to do it within the realities of our capitalist system and how medical technologies are delivered to the hospital. So ultimately, we've had 45 startups, which we define as companies that have raised at least $500,000 externally, not just a couple students who say we're a startup and I'm the CEO, but have really externally validated through funding. It's created quite a few jobs, and then we spawned all these other programs. From the fellowship, we're now up to 200 graduates, and as of this year, we just hit 1 million patients touched by products that have come out of biodesign. In terms of surgical trainees, we've had 24 surgeons come through the program, not all Stanford residents. To be clear, we have taken surgical residents from other programs, WashU, Northwestern, et cetera. 7 are still in training. This is an interesting one to me. 11 that have gone out are actually full-time academics. That's a pretty good percentage of people trained. So while not a classic academic path, it has led to people at least getting assistant professor positions, so we'll see where it goes from there. There are a few people who have chosen not to practice surgery, so 3 of them, and I think this is another maybe misperception that you go to biodesign, never come back to surgery. That does happen. I think that also happens when you go to basic science labs and other places if you just don't want to be a surgeon, but we do have 3 people who have gone on to be, you know, CEOs, entrepreneurs, et cetera, as a full-time job, and a couple people in private practice. We've had about 20 surgery-related technologies. I'm not going to go through all these, but these were not necessarily developed by surgeons, but by our multidisciplinary teams. Not all of these are going to make it to the market, but there are a few that are out there. Neodyne was developed out of one of our labs, is now a scar healing product. Prescient, which is for preventing surgical site infections. Again, won't all make it to the market, but these teams all dove deep on surgery and helped try to address our unmet needs within this department. In addition, there's been, some of these are overlaps, but these are technologies developed by surgeons, which interestingly, the majority of don't address surgical needs. So for example, William's need around asthma is not really related to anything we do surgically, but it was a Stanford surgeon who was involved in that. Other examples of Lully, which is dealing with sleep terrors, and then many that do relate to surgery, from development of a new kind of Bovie system all the way to non-invasive anastomosis of the bowel that can be done endoscopically. So again, I won't go into all these in detail, but just to show you some numbers and you know, real devices and real technologies have come out of the program focused on the Department of Surgery. And I think a lot of that is due to us early on being a proponent of this program, really being co-founders of this program, and providing both the resources and the people to help develop these things. We are trying to be academic as well. That's something that's important to Dan and I, that we publish on what we do. It's, you know, seeing where the most mature of the companies is with William, mature in terms of years, that they're 4 years out now. You can see a lot of what they're doing, even with private funding, is academic work, right? They just ran a randomized control trial. They're publishing on it. These are all things that are important to the success of a technology as well as to an academic career. So we've had 39 peer-reviewed publications. That's as of 2016. We need to update that, so we certainly have had a few more since then. In terms of funding, the culture program, we've had at least one person from the Department of Surgery every year since 2006. We've had about $1.8 million in culture funding go to the department, but what's interesting is follow-on funding to that has been over $50 million and continues to grow. Spectrum programs also helping support some of these. The 1 million patients treated is a big number for us this year. The fellows trained is a big deal. This is really our product, is both the fellows as the cornerstone of what we do, but also faculty, students. So I think with that, we'll leave it for questions. Thank you all so much for the opportunity to kind of talk about the program, and love to hear a good discussion. We'll let you know the Shark Tank results and whether you need to stay or go home shortly. Thank you.